Share my slides. Okay. Can everybody see my screen okay? I'll do the standard Zoom answer. Okay. So hi everybody. I think I've met several of you over the last couple of months at different events. So I'm Melissa Peterson. I'm an assistant professor at the University of North Texas Health Sciences Center. I'm in both the Department of Family Medicine as well as the Institute for Translational Research. I'm going to be presenting today on aging, Alzheimer's disease, and Down syndrome, just to give sort of some background on myself. So I spent most of my training, so I'm a neuropsychologist. I received my PhD from the University of North Texas. I'm specialized in clinical psychology, but majority of my clinical training has focused on dementia. And my research really that I've published over the last 8 years has focused on blood biomarkers and being able to use the blood to detect cognitive changes, particularly Alzheimer's disease. So that is sort of how I was asked to join kind of a larger group doing research in Down syndrome. And that's sort of where I am and what I'm doing today as sort of background on me. So to just kind of give an overview of the presentation and the objectives, I'm really hoping to give sort of an understanding of features of Down syndrome across the lifespan, talk about the pathophysiological links between Down syndrome and Alzheimer's disease. That is a very extensive, complicated discussion. So I've pared it down considerably for the sake of time and to allow for more questions, but I'm happy to do additional talks in this area. I'm also going to talk about some of the limitations in diagnosing Alzheimer's disease and really cognitive changes among individuals with Down syndrome, and then some early signs of cognitive changes and things to look out for. So Down syndrome is, as most of you know, the most common genetic condition and really one of the most common causes of intellectual disability. It occurs between 1 in 700 births in the US with an estimated a little over 5,000 average per year. It was initially described by J. Langdon Down, which is where the name came from, in 1866. And it took considerable advances in technology and our understanding in science to finally identify it as a chromosome 21 trisomy. And that happened around 1959. And I'm happy to say that the lifespan for individuals with Down syndrome have grown exponentially over the years. And so the topic of aging has really been a popular one. Part of this is due to improvements in medical care, advocacy, health policy. And so life expectancy has really doubled over over the past 30 years or so. And so estimates place about 75% of individuals with Down syndrome are expected to live into their 50s, with around 25% expected to live well over 60 years old, which is great. With aging, there do come a number of medical comorbidities that we see. Some of those are things like hypothyroidism. So you have an underactive thyroid gland, and that can cause fatigue and mental sluggishness. You can also have vision loss. So there's been a lot of work coming out with regards to visual deficits in individuals with Down syndrome. They're prone to develop cataracts early on. So that can be the clouding of the lens, as well as keratoconus, which is the distortion of the cornea of the eye. So it can impact kind of visual acuity and can distort images as well. Hearing impairment is another comorbidity, and part of that can be due to wax buildup in the ear, both the small and narrow ear canals, which can impact communication. There's also a high rate of obstructive sleep apnea, which is a sleep disorder. Osteoarthritis, which can cause pain and stiffness. And some of these, so I have them highlighted in kind of a light yellow color. can actually simulate learning and memory difficulties. So things like the underactive thyroid gland, vision loss, hearing impairment, all of those can simulate potential difficulties when in fact it's due to another reason. So it kind of raises the importance of making sure that you're following up with the primary care providers, getting that annual exam to check the thyroid, following up with ENT docs, with the ophthalmologist to make sure that there's no vision loss accounting for any of these potential changes. Other medical comorbidities that are experienced, dementia. So as individuals with Down syndrome live longer, their risks for developing age-related conditions increase. But they actually have a really high prevalence rate of dementia, specifically Alzheimer's disease. And those estimates range anywhere from 30 up to 50% for those in their 60s. And part of that risk for Alzheimer's disease is related to trisomy 21. So chromosome 21 encodes for what's called the amyloid precursor protein, APP. Overexpression of this protein is involved in the production of what's called beta amyloid. So it contributes to the amyloid pathology of Alzheimer's disease. Chromosome 21 also is involved in the overexpression of the DYRK1A and ARCAN1, which are involved in the hyperphosphorylation of tau. So chromosome 21 holds extra genetic material for the development of both amyloid pathology as well as tau pathology. And Alzheimer's disease is created or thought to be linked with both of those developments. So that is why individuals with Down syndrome just face a much higher rate of this disease, because they have this pathology in excess relative to the more general population. And so they've done quite a bit of work over the years to try to understand sort of when individuals with Down syndrome start to develop this different pathology. And what they found is that amyloid actually develops pretty early on. They found it starting in some studies around age 13 years old. And that was intracellular. You can see that here. By the time they hit 30s, that's when you start seeing it extracellular, and you see it in the blood vessel walls of the brain. So that's more indicative of the Alzheimer's disease pathology. And by the time you reach your 40s, what they're really finding is that most, if not all, individuals with Down syndrome have both the amyloid and the tau, so the neuritic plaques and the neurofibrillary tangles, for actually a neuropathological diagnosis of Alzheimer's disease. But what I want to note, so even though you have this increasing pathology over the years and it develops earlier on and at higher rates, there is a subset of aging adults with Down syndrome who do not develop the clinical signs of dementia at any age. So even though you have this increased development of pathology, not all individuals will develop Alzheimer's disease. So I just want to make that note. They've looked also over the years on sort of the progression of Alzheimer's disease. And so the top figure shows those adults without Down syndrome versus those on the bottom figure shows adults with Down syndrome. And the models look very different. The changes that they've linked with Alzheimer's disease occur very similar. But what I want you to note is that how far away these changes occur is much broader for adults without Down syndrome versus those with Down syndrome. So for Down syndrome individuals, those occur in a much more succinct sort of onset. The age of onset and the age of these changes also is quite different. So I included this red arrow to kind of show when these essentially line up. So this model starts about 50, which is here for individuals with Down syndrome. So Down syndrome start to experience this cascade of changes at least a decade earlier than the neurotypical population. And so they experience it also at sort of a greater rate of change as well. But they do experience the change in the amyloid. Then you have the tau, you have what's considered volumetric MRI changes. So that's where you actually see changes in the brain structure itself. And then you have changes from a clinical stance where you have changes in cognitive functioning, as well as functional abilities. So I'm going to take a second because I've talked about dementia and Alzheimer's disease and use those sort of interchangeably, just to kind of give some background information because I get asked this a lot. Dementia is actually a broad term that captured conditions that impact memory, thinking, and daily functioning. So you can think of it sort of as this umbrella term. Under that umbrella includes Alzheimer's disease. So it is the most common type of dementia, but it's not the only one. So there are other types of dementia like a Lewy body dementia, vascular dementia, but Alzheimer's disease is the most common by far, occurring anywhere from 60 to 80% of cases. It is a progressive brain disorder, and brain changes occur. I kind of put a little note for the neurotypical population. So for the general population, you can see these brain changes for 10 to 20 years prior to symptom onset. Obviously, that's a little different for individuals with Down syndrome who see it starting earlier in life, and then they have a more succinct change in their progression. The symptoms of Alzheimer's disease, and this is provided from the Alzheimer's Association, can really be broken up into sort of 5 different areas. Learning and memory changes, changes in executive functioning, language, orientation, and mood. So those are the 5 sort of big areas that we're looking at. Changes in learning and memory associated with Alzheimer's disease can include difficulty learning new information, recalling important dates, events, repeating questions, misplacing personal items, having to use more of what we call compensatory strategies. So that means you're making more lists, you're setting reminders on your phone, kind of using different strategies to help offset some of these changes and difficulties. Executive functioning really encompasses tasks like planning, organizing, multitasking. You can see difficulties in this area sort of manifest in one's ability to manage their medications, do financial management, pay bills, leave a tip, make change. It also shows in with regards to judgment, social behaviors, problem solving as well. Language symptoms include trouble with word finding, name retrieval, difficulty with conversations, and then orientation is difficulty recalling the date, the season, as well as spatial orientation, like where you're going, how to navigate, get from one place to another. Mood changes are really sort of broad. They can range anywhere from confusion, paranoia, to anxiety, depression, increased irritability. So it's very variable in that. And the progression really sort of depends on the functional impact of these cognitive changes. So the preclinical AD is where you're not really presenting with any cognitive changes or functional changes. The mild cognitive impairment is considered when you have some cognitive changes, but you're able to still function in day-to-day life. You're still able to manage your medications, pay bills, drive, do all of those activities. So that functional impact hasn't been reached. But once you hit those purple, so the mild, moderate, or severe of dementia due to AD, that means you have enough cognitive changes that it impacts your ability to do day-to-day activities. And then it's sort of the severity of how impactful is it. For individuals with Down syndrome, the changes are similar, but a little bit distinct. So I wanted to go through some kind of early signs of what Alzheimer's could look like for those with Down syndrome. Memory loss that impacts daily life is probably the big one. So there may be confusion or forgetfulness of recently learned information or information that was recently told to them. So they may be asking for information to be repeated, even though maybe it was just discussed. It may also manifest as difficulty planning or solving problems, particularly if it's multi-stepped or if it requires a sequence. So you can think of examples where bringing a towel with them to the shower, or wearing shorts when it's snowing outside, or not packing a sandwich with their lunch. They packed everything else, but a key piece was missing. Difficulty completing familiar tasks or tasks that they've done well in the past. So this may be like a decrease in their productivity or confusion in completing tasks. This may manifest, an example might be they're forgetting how to call a family member, even though they've dialed and called this family member every day after dinner for 5 years. Now they're having problems doing that task. They have confusion with how to use their phone, how to make that call, or even what they're doing. Confusion, disorientation to time and place. So they may be really agitated, not really sure where they're at, what's going on. Trouble with understanding visual images may be another one. So difficulty kind of interpreting some of the pictures or signs, trouble even navigating familiar locations. Again, I mentioned the importance of kind of getting those eye exams because it may be due to the keratoconus or the cataract development that they often see that occurs with aging. Problems with language is another one, and probably one of the earlier signs. So they've kind of started teasing out what may be. So of these early signs, what may be some of the earliest, and problems with language is probably what their consensus is on sort of the largest change for this group. And that is a decrease in both their expressive and their receptive language ability. So that may be shown that they're using kind of shorter sentences. They're using more simplistic vocabulary to communicate. They're maybe not hearing everything that's being said to them. So they're having a hard time even repeating back some of the information that's being told to them. So this change in language is most distinct for adults with Down syndrome who also are developing Alzheimer's disease and showing early signs of it. So again, that's one of the earliest signs of the early signs. Changes in judgment is another one. So maybe not locking a door like they used to keep safe, throwing items away that are actually of value, maybe new impulsivity or a decline in their safety awareness. Other signs may be more mood, personality, behavioral. It could be withdrawal from social activities, confusion, suspicion, irritability, paranoia. So the mood and behavioral changes are also considered to be one of the earliest signs with regards to these early signs of AD in adults with Down syndrome. The changes across the lifespan. So the pattern and sequence of the cognitive impairment in adults with DS is similar to the general population. You saw similar patterns with regards to changes in memory, language, orientation, but the presentation may be a little bit different. As I mentioned earlier, kind of the percentage of decline in the verbal ability is far greater for those with Down syndrome. And that is in comparison to individuals with intellectual disabilities who do not have Down syndrome, as well as in contrast to the more general population. And you see the cognitive decline quite a bit earlier than you would in the general population too. So again, those kind of onset of changes occur, they estimate around 30 years. We've seen it in our own research, and at about age 40, 45 is when we start seeing kind of this higher change in cognitive abilities. Diagnosing dementia and Down syndrome is a challenge, and that is part of my field. So there's not actually a definition of dementia specific for individuals with Down syndrome. They've tried to sort of refine this over the years. What we have in the dementia space is sort of a structured criteria with the notion that most people perform in the average range on their cognitive testing and in their intellectual abilities. And so what's happened is there's been more of an emphasis on sort of these non-cognitive aspects of dementia when diagnosing individuals with Down syndrome. And so you're looking at more of these behavioral mood changes, as well as kind of the importance of a baseline functioning. So the diagnosis requires sort of a change in status. So it shows that individuals could once do an activity and now they're no longer able to do that. And that's a decline from their baseline. And so longitudinal assessments are really very useful in documenting both kind of the baseline functioning. So where they were, where an individual with Down syndrome was, 5 years ago versus where they're at now, and do a comparison with current functioning, current abilities. And the same is included. So not only cognitive abilities, but also behavioral functioning as well. And the period that they sort of are looking at is about 6 months, but we generally want longer if possible. Because it is incredibly challenging to diagnose dementia in individuals with Down syndrome, there's been a lot of work recently looking at sort of ways to do this in a more efficient way. That is where sort of my own research comes into play. So we've looked at using your blood to be able to detect cognitive decline and the onset of Alzheimer's disease, particularly in adults with Down syndrome. And we've shown pretty excellent findings with regards to that. So it is promising. We're hoping to further refine that down. They've also looked at other ways of like looking at pictures of your brain, looking at cerebral spinal fluid markers, which link more closely to the central nervous system for diagnosing Alzheimer's disease. And those are both incredibly accurate, but they pose a lot of limitations. They're very invasive, very costly, and the demand that is put on the individual undergoing these is far higher than just getting like your blood drawn, which you would get at your regular primary care visit to get your glucose level, your white blood cell count, different things like that. So the blood biomarkers hold a lot of advantage over some of these other modalities. And I could do a whole lecture on what we're finding within the blood to be able to predict it. But for the sake of time, I didn't really go into that. With regards to evaluating and determining dementia and Down syndrome, a lot of that has had an emphasis on neuropsychological assessments, but it can be challenging. Part of that is with regards to the variability of sort of the baseline cognitive level. So individuals with Down syndrome can start at varying levels. Some of them function very, very well, have a higher cognitive intellectual level than others. There's also a lot of heterogeneity with regards to the presentation. What does their symptom onset look like? What's been impacted? And our tools that we use for assessment are just not as robust as they are with the general population. Although over the last, I'll have to say 10 years, there's been really a push to develop very specific tests for dementia in individuals with Down syndrome and in individuals with intellectual disability. So I think there at this point are about 6 really good measures that we have currently that we are able to use in a clinic setting to help look at these changes. There's also concerns for what we call floor effects. And that's because most of the measures that we have really aren't suited for individuals with the more severe intellectual disabilities or even dementia. And it really falls into the importance of family and caregiver reports. So if individuals are in a residence and their caregiver turns over every couple of months and they don't really have a good report of how this individual is functioning over the last couple of months, let alone 6 months, let alone a year. And that's really a lot of the utility, because that's kind of the big change of personality and mood can come from those family and caregiver reports of sort of the day-to-day of, okay, well, they used to be able to dial the phone and call their family, and now they're having confusion and I'm having to dial that number for them, or they're missing a number and I'm having to go in and help remind them what that number is. Those are the day-to-day things where individuals with dementia generally don't have awareness of, and our basic sort of measures don't really assess for that. So that's kind of where the importance of individuals, of family caregivers who really know that individual can play just a significant role in helping with the determination of if there's been that change. The HSC Health Clinic, we have a neuropsychology practice here, and we do see adults with Down syndrome if there's a question of dementia. So I listed the number there. So there are resources available that are able to kind of do those different evaluations if there is a question of it. And I just wanted to give that resource to you guys. With regards to caregivers of adults with Down syndrome, the recommendation is that in response to the decline in learning and memory and the onset of Alzheimer's disease, there may be the need to adjust some of the traditional methods of approach for individuals. So previously, if you were interacting, if you were the caregiver of an adult, and used incentives or rewards, that may become counterproductive because that requires an individual to actually remember what that incentive is in the short term. And the fact that if they do this particular behavior, like that will lead to, you know, that incentive. The benefit of that gets lost because they don't recall, you know, what that incentive is or the reasoning behind it. The ability to learn and recall new rules might also decline, as well as kind of the utility of negotiating or using logic or reasoning declines as well, because the understanding of the information declines over time. With regards to kind of communication, some tips are that nonverbal communication may become key and really helpful. So individuals with Alzheimer's disease tend to rely a little bit more on the emotional cues to interpret information versus what's being actually said to them. Again, they have that change in that understanding of information. So the tone of the voice, the facial expressions, the body language, all of that can actually be incredibly helpful in communicating. The importance too can be placed on the atmosphere of the environment. So conveying that it's safe and nurturing. So, you know, body language like smiling, avoiding negative tones can all be helpful. Trying to avoid negative words like no, stop, don't might also be useful, and shifting it to more positive or neutral language and try to redirect the conversation if possible. Some communication tips, again, for caregivers of adults with Down syndrome and Alzheimer's disease. Short, simple words and sentences can be incredibly helpful. Breaking things down into one-step directions so that they're not having to multitask can also be helpful. Asking
Hi.
one. Hi.
Hi, girl. Oops, sorry.
That's okay. Did you have a question? Asking one question at a time so that they can answer that one directly versus bombarding them with multiple questions that they may have missed or gotten confused about answering all of them. Another couple of suggestions might be providing choices or suggestions over open-ended questions. So for example, what do you want for breakfast? Could be more efficiently said, would you like cereal or pancakes? Because that gives them a choice and they don't have to then generate that information for you, which could be lead to frustration, irritability. You may have to repeat information or questions, and that generally happens and is sort of our tips for any caregiver dealing with an individual with Alzheimer's disease. And then also the utility of making statements rather than asking questions. So rather than do you want to go, say let's go, can also help with regards to the behavioral activation. And then as I mentioned, so there are also some behavior mood changes that can also occur, particularly early on with regards to individuals with Down syndrome who develop Alzheimer's disease. So it's important to kind of keep a lookout for what are potential behavior triggers. So there can be a lot of frustration due to potentially the complexity of a task. If it's overwhelming, they may become more frustrated. And you just, if you're on the lookout for it, that can help kind of ease the situation. Environmental stressors, to be aware of those, there are loud sounds, poor lighting, disruptive behaviors of maybe others might become overwhelming. And so that may sort of be a trigger in and of itself. personal changes. So passing of loved ones, changing of staff members can be disruptive, and communication problems. So misunderstanding of others or what is being asked can also lead to increased frustration. So kind of the helpful things might be to provide reassurance, neutral, positive communication, use redirection or distraction if possible, and then try to keep yourself as patient, calm, and aware of your own stress levels as you can be, because as a caregiver, if you become stressed, then they're feeding off of that nonverbal communication, and that can sometimes cause a trigger as well. So being sort of self-aware of your own behavior as well. So there's a number of resources. There's a couple of guidebooks for caregivers. There's some different resources with regards to like a Down syndrome clinic and the Alzheimer's Association. So those are all kind of just different resources and information tools that they can be used to get a little bit more information about Down syndrome, medical conditions that occur as you age with Down syndrome, and then as well as Alzheimer's disease and Down syndrome. I would like to send a big thank you to the Down Syndrome Partnership of North Texas for having me speak today. And I have a ton of resources, and I am happy to take any questions that you guys have.
On the medical side of things, do you know anything that helps to prevent it? I read an article once about like different supplements and things like that.
They've done, it's the same as with the Alzheimer's space in the general population. They are treated with cholinesterase inhibitors like donepezil, memantine. So the same sort of treatments have been provided in the Down syndrome population, same as in the general population. There's actually been a big push to focus on enrollment of individuals with Down syndrome into clinical trials, because there's been a gross underrepresentation over the years. And so they're trying to, there's actually a whole focus of the NIH trying to really drive to include adults with Down syndrome, to really see the application and if there's any other medications that we could potentially use, because they've done other studies over the years like NSAIDs. They did a rosiglitazone trial, diabetes medication to help with treatment of Alzheimer's disease. But again, all of these were focused in the neurotypical population, and so they don't actually know the application to adults with Down syndrome.
And what did you say it was? Because I heard two different messages. One was that it was like 100% chance of developing it, and then once it said 50%. So did I miss something?
It depends on the, okay, yeah. So they think by around 40, most, if not all individuals with Down syndrome have the neuropathology of Alzheimer's disease. So they have the neuritic plaques and neurofibrillary tangles. But the prevalence of Alzheimer's disease among those in their 50s is about 30% who actually have the clinical defined disease. 30% for those in their 50s, and then 50% of those in their 60s. But they do have the pathology. But just because you have the pathology, just because you have the amyloid, doesn't mean that you're going to have the clinical presentation of Alzheimer's disease.
And that's what's detected in the blood work?
Yeah. And they also are doing PET scans. So they've looked at the amyloid deposition in the brain, and they've actually found very interesting findings within the last like 2 years, that there's actually certain parts of the brain that sort of accumulate the amyloid earlier, and they can sort of track the progression of it. And so they're trying to see if maybe this is a good indicator of diagnosing the disease before you have the clinical manifestations of it. So it's, I think CA125 is the location of the hippocampus. Yeah, a lot of information. We've done a lot of work in the last really decade in this area, which has been really exciting. And I feel like there's a really strong emphasis on continuing to advance our understanding, and the ability to diagnose this earlier is really important. just because you have this development of amyloid so early on. I mean, the studies are kind of indicating the start of it, that you can see it in the brain about 13, is really early relative to kind of the general population, where you see it much later in life.
So is there some kind of information that's going out? Should we be looking at these markers earlier in the medical community? And if you do find them, are they like, what is available to reverse this, or what should we be doing if we do find it?
Yeah, those are excellent questions. We don't have the answer just yet. So my personal research has looked at proteins in the blood to be able to predict earlier onset, but we haven't refined that down to really saying, okay, if they have this panel, so essentially a blood test, if they have this panel, and they test positive on this, to go on for confirmatory. We're getting there. We're also getting there in the general population as well, to kind of essentially create a blood test for Alzheimer's disease. We also don't really have really good treatment just yet. So the FDA like approved a monoclonal antibody, aducanumab, for amyloid removal in Alzheimer's disease, and like it's MCI stage, so kind of the prodromal stages. But even though, and if you look back in the publications of the work, and if you look on clinicaltrials.gov, they actually stopped the phase 3 of the clinical trial. So even though the amyloid was removed, it didn't necessarily improve the Alzheimer's symptoms. So the primary outcome measure, the cognitive functioning, the functional abilities, did not really improve. And they did some background stats afterwards and showed that, well, at really, really high dosage, there was like a 30% reduction, but you had higher rates of brain swelling. I think that occurred in like 40% of the population. You also have ARIA, which is like brain bleeds. So there's a lot of higher risk for removal of amyloid in the brain, relative to like donepezil, so Aricept, which has more of GI complications. And that's what we currently have in the field. And that's what we've had for several decades now as a form of treatment. So even though they gave approval, but it's contingent on it showing utility moving forward, it's really still, it has a lot more risk, I think, than benefits compared to what we currently have as a treatment for Alzheimer's disease. And our treatment is not to improve cognitive functioning, it just slows decline. So as a field, the question is, if we can get them earlier. So it's in a head clinical trial, it's A4, A5. They're looking at individuals without cognitive impairment who have amyloid. And if we give them an infusion to break up the amyloid, will they just never go on to develop Alzheimer's disease? So that's sort of the question. They tried it with individuals with Alzheimer's disease. They broke up the amyloid. It showed no benefit. So essentially, there's been a chicken and egg question. And even though we were able to remove it, it didn't help. People still had the cognitive changes, the functional declines. And so the question, really being able to study this in individuals with Down syndrome who develop amyloid very early on, I mean, this is a really interesting question of, does this actually impact it? So even though we found this neuropathological link between these two areas, does this really contribute to it, or is it these other pathways? And there was a model that I showed. So they have oxidative stress, they have inflammation. And what we're finding with the blood is a lot of our profiles are very heavy on the inflammatory markers, both general as well as the pro-inflammatory cytokines. And so the idea is that there's probably the symptom disruption going on. And so, I mean, it could be as much as, it may be more appropriate to have like an inflammatory medication, like an NSAID as a treatment, to kind of help this cascade of events versus like an amyloid medication that breaks up the drug. So It's a very complicated question, and I appreciate you asking it. It's a hard one, and hopefully we have a better answer for it in the next couple of years.
Thank you.
Two questions. One's probably silly, but does it make a difference either way if Alzheimer's runs in your family or not?
Yes. So there is a genetic risk, and I didn't really talk about it, but it's the apolipoprotein E. So you inherit 2 sets of chromosomes from your parents. For ApoE, this gene, you inherit either a 2, 3, or a 4 allele. If you have a 2 allele, it's protective. So you have a lower risk of Alzheimer's disease. 3 is sort of neutral. It's neither good nor bad. And 4 is an increased allele. So if you have Alzheimer's in your family, it's likely that there's a 4 allele running through. And so your risk increases from having that gene.
And then, sorry, go ahead.
They have those genetic kits like 23andMe where you can actually find out if you have that gene, the ApoE4.
And then my other question is, so my brother just turned 39, and mom and I have kind of talked about the whole possibility of Alzheimer's popping up in him.
Mm-hmm.
Since he turns 40 soon, and that seems to be the age where symptoms could kick in. I mean, would it hurt to go ahead and have our GP start testing his blood now?
So we don't have a blood test just yet. And it may not be useful just yet to go through like a neuropsych evaluation. It may be just you guys watching out for any sort of changes. So changes in personality and mood. Is he more irritable? Is he frustrated? Is he giving up on tasks a little bit easier than before? Language, is he kind of truncating what he's communicating, using more basic words, getting more frustrated when you're asking questions? Those are things to look out for, because those have actually been sort of the bigger indicators that there's been a change. So you as family are probably the best measure that we have right now.
Okay, that's good to know.
Yeah, but once you start seeing those changes, tell your practitioner, because then it would be useful to get a neuropsych test and get a diagnosis and get on medication for what we do have for the moment.
Right. Yeah. Because some of the signs you talked about in there, like asking the question, what do you want for breakfast? Do you want cereal or pancakes? We kind of do that just in communicating with them anyway. And so I don't want to go off and be like, oh my gosh, we need to worry. But he is also like generally a super happy person. So I'm sure behavior, that's probably going to be the first thing we see then if something happens.
Yeah, hopefully not.
No, yeah,
You never want that to be. So the earliest of the early signs, again, are those changes in language and then the mood and personality. So those are sort of the bigger flags that they're finding. And they actually did one study a year ago and found that there was like a questionnaire for the caregiver or family, and it asked about personality changes, and that ended up being like the biggest flag for if they had sort of that change in progression. So again, just you guys keeping an eye out of like, he hasn't usually responded this way, or he's getting a little more agitated than before. And again, check on things that might be easily fixed. Things like maybe he's having new onset vision problems or hearing loss. And so he's just not seeing what he needs to, or hearing the question. So he's now getting frustrated, because those are things that you can actually go and get fixed very easily, and they can have a positive impact on functioning. So just make sure it's not something else going on.
Yeah, we've definitely done that, because he does get wax buildup in his ears. So that we did learn that one.
UTIs are another one too that can cause memory problems in addition to thyroid. So if they're talking about, it's painful to urinate, definitely check up with your primary care doc, because that's another easy one that can impact memory and thinking, that can be treated with an antibiotic. So.
Good to know. Thank you so much.
Yeah.
Did anyone else have any other questions for her?
I have a couple really short ones. Have you seen a higher incidence in autism for people that are dual diagnosis, autism and Down syndrome? And then secondly, what kind of adults do you see at your clinic?
So I can't touch on the one with autism.
Have a child that we've been to the Down syndrome clinic in Arkansas, neuropsych, a whole bunch of places. Do you general? Yeah.
I think I missed the last half of that question.
Can you hear me? Did I freeze?
Yeah, I think
did.
Okay, I'm sorry. Did you hear my dual diagnosis? If there's an increased chance for dual diagnosis, that was my first question.
Okay, so I can answer that one in the fact that I don't know the answer to that. So
Okay.
autism is not my area, so I do apologize. And then I think the second one was, who do we see in our clinic here? And it's just adults in general. And we do see adults with Down syndrome if there's a question of cognitive change, potential for dementia.
Okay. And so, and Heather has your contact information, or like, how would we?
She does. And I can also give you guys my PowerPoint slide, and it's on there. So it's so we're at the University of North Texas Health Sciences Center, and there it's HSC Health is the clinic. And there's a neuropsych practice in the Division of Geriatrics. But we see adults and older adults with any sort of cognitive problems. But there's the number was on there, but I can also give that to Heather too. So that way you can contact and just have that as a resource if you guys need it. We're located downtown across from the Kimball Art Museum. So down by the Stockyards in downtown Fort Worth.
Okay, thank you.
Hi, you're welcome. And it's a full practice. So there's 4 including myself, 4 neuropsychologists, which is a lot for a location. We're not a big specialty area.
So I'm just wondering, so you guys could probably rule out things as well, like just, because my daughter's young, but the last 2 years has been a lot of changes, but we thought it was regression, then we're told something else, but I'm like, so I'm kind of trying to figure out, I've been told specifically, it can't be Alzheimer's, but I'm also wondering if maybe you guys could give us some advice on what else could we be looking for? Do you know what I mean?
Yeah. And it depends too on the age. There is a subset of individuals who do have regression. I know in the research, so I'm a part of a really large consortium, and we had, out of the 329 adults with Down syndrome, we had 8 regressors who had worsening of their expressive language abilities, as well as, so their difficulty in language, both speaking, hearing, behavioral problems. So it was like a full regression for them. And they were looking at sort of the reasoning behind it. So there is some literature in the fact that does happen, but I don't think we have a full understanding of why. They were trying to pull out and look at blood biomarkers to try to figure out what's going on. And why is it, why was there such a quick regression in such a fast time?
Okay.
So I know it does happen, but we don't have a lot of literature on what might be going on or the reason behind it. I think they're still trying to tease that out. But I know personally, people at Pittsburgh who are trying to really look at this, because we don't have an answer, but we have seen it. But again, in the 329 people, I think we have in the cohort, 8 people experienced it, and it was across genders, and but it was younger folks, like in their 30s.
Okay, thank you.
You're welcome.
Are there any other questions? And Donald, let's see that you got on here just a little bit ago. It's recorded and there's a PowerPoint presentation, so I can share that with you.
Okay, yeah, that'd be great.
Yeah, it's a lot of information there. Okay, well, thank you guys for logging on. Thank you, Melissa, Dr. Peterson, sorry, for your presentation. That was a lot of information, like a lot. I was like, oh wow, it's a lot of science.
It is, and I cut a lot too.
Yeah, like, man, I was trying to follow that. That was not my subject in school.
Yeah, it's been really, really interesting. And if I got into like the imaging pictures too, of like the changes, like it's very, like our advances in science have been considerable. And so it's been very interesting to kind of track this and get a better understanding. But the brain is still, we consider it to be a black box. Like we still don't fully understand. We don't understand it in the regular, the general population, let alone in individuals with Down syndrome. So we're still trying to figure this out across the board. And
yeah.
I'm really hopeful though, at the rate we're going, that we're going to have a lot of answers here in the next couple of years. I think we're really, as a group, we've done a lot more collaborations. We've really focused, even at the government level. So the study that I'm a part of, I just run the blood work for it, but they actually combined 2 different cohorts. The government came in and said, okay, we have like a young adult cohort and you have an older adult cohort, but that's still a study of Down syndrome. And so they asked them to combine it so that we could look across the span, do the same measures on everybody. So I think that, like, as a community, we're really coming together even more, trying to find answers and get numbers to say, okay, now, so of those, 300 and something, like, we saw 8 regressors. Like, that would have been, 2 in one grouping and, maybe 6 in another. So there wasn't a lot to look at. But now that we have this larger group to look at, we're finding more and trying to figure out, what's going on, trying to get answers. So
yeah,
hopefully we'll get there.
That's good. It's good to have you as a resource and stuff. So I'll share that information with everybody and put the presentation out there, and it had that phone number on there for people to call if they needed more information. So, all right, guys. Well, thanks for logging on. Y'all enjoy your evening, and we will see you later.
All right, thanks,
Thank
guys.
you.
Bye.
Bye.